you are live.
So with the corona, everybody has learn to accept the silence that is there.
Silence has its own words.
Yeah, its own language.
Dr. Kamlesh, you are looking like another man from another planet.
Yeah.
I know. Well, my kids have done. I don't know how they did.
So what time is it, Mr. Dr. Mark, at your place?
It is 9:30 in the evening.
Evening, all right.
In the evening.
So what is your routine? What is your routine sleep time?
About now. So
Spontaneous.
it'll be a late night for me. I have to have a nice cup of tea. No, we'll be normally asleep a little bit later, but tonight we'll be very late.
Navin bhai.
Just a minute. It will take 2-3 minutes, sir. Where I posted, yeah. Orthopedic Academy, yeah.
You have to press some special buttons, yeah?
Okay. No, I have to, yes, I have to generate the key. I have to generate the key so that I can make live from them. So now we are live, actually, for all the delegates. So I'm putting an introduction with the permission of Rajiv bhai. So on behalf of Gujarat Orthopedic Association, myself and Dr. Kamlesh Dev Murari is welcoming all faculties here. Thank you, Dr. Mark, Dr. Chow, and Dr. Mahendra, and Dr. Nikesh. Thank you very much for accepting our invitation and making effort to contribute to the whole delegates. So just for the delegates, what you see on your page is there is a link for recordings of the previous webinars. But as you go down, there is a red arrow here. You can see Kamlesh bhai here. Just click here and you will be able to see the webinar completely. And it is about the office practice issues for foot and ankle. This is the third webinar of the foot and ankle. And Dr. Rajiv bhai is going to moderate it. If you have any question, there is a Slido window here. Just type your question here and click the send button. Immediately it will come to me and I will throw to the moderator and the faculty. If you do not want to type it, just record your audio or record your video button in the camera itself in the WhatsApp and click this button. The WhatsApp will come to me and will put that question in an audio or a video mode. So everybody knows Dr. Rajiv Shah sir. He is a very known figure in foot and ankle, international figure. Let me introduce Dr. Mark from Australia. He is the chairman of the Asia Pacific Foot and Ankle Council. And Dr. Yok Pin Chua from Malaysia is the secretary of the Asia Pacific Foot and Ankle Council, and he is going to share his experience with us. Dr. Nikesh Shah, our own from the Baroda, is the past president of Indian Foot and Ankle Society. And Dr. Mahendra from Goa is the president-elect of the Indian Foot and Ankle Society. I will be just coordinating the whole panel and the audience. I'll be the connecting person between the audience and you people. So whenever I want to stop, I will stop you. If it is appropriate, please bear with me. For the delegates, let me show something, another thing also. There are a number of webinars are coming with different topics, and we are following the demands and feedbacks from the all faculties, all delegates. Here is the 28 number is already booked for complex THR and primary THR, where there is a galaxy of faculties, and they will say their experience. These are coming, and these are with supported with the Jaitus people. And another is fixed about the TKR. You can see here that is the 29th number webinar. Again, the galaxy of the speakers. Here, Dr. Deepak Dave is moderating both the sessions. This is third and fourth. Previous two, knee and hip, was fantastic. And let me tell you that again, the periprosthetic infection, Dr. Javed Parvezi has accepted the invitation from USA. So he's going to share his lifetime experience about periprosthetic fracture. The same way Dr. Arcos has accepted the invitation from Germany from Endo Clinic. So this is just for the information of the delegates. Now, Rajiv Bhai, you can take the screen on your side, please.
Thank you very much, Dr. Navin Bhai. And needless to say that this all webinars have been possible because of untiring efforts by him. We are fortunate that we got a president at the level of Gujarat Orthopedic Association who is very much enthusiastic to go ahead and do with this kind of webinars. And I sincerely appreciate his efforts. Coming back to...
Thank you, sir. Thank you. Dr. Kamlesh Bhai also wants to invite for a 1 minute, sir.
Yeah, please, Dr.
Then
Kamlesh.
he will go.
Yeah. So good evening, all viewers, and thank you all faculties to joining in this platform. So yes, Rajiv Bhai, you carry on. Thank you very much. Yeah, thank you.
Thank you, Kamlesh Bhai. And I would start sharing my laptop. Here it is. Right.
Yes.
So we are going to talk on to office issues in foot and ankle. And this is in absence of patient. This is going to be a case-based evaluation where we want to come to the diagnosis and differential diagnosis of the very common ailments which we encounter in our OPD practice. And we are also going to touch upon the treatment part. And I have my esteemed panel as Dr. Navin introduced. Mark, again, happy birthday to you. Yesterday was your birthday. Today in the Australia, it is like time for you to go to bed. Thank you very much for being with us. And at the end of the webinar, I'm going to give you a time slot where you could introduce what is Asia Pacific Foot and Ankle Council and how do you want to collaborate with the other associations. So Dr. Mark is from Australia and he is the chairman of Asia Pacific Foot and Ankle Council. Dr. Chua, young and dynamic secretary of Asia Pacific Foot and Ankle Council, is a very close friend and is a dedicated foot and ankle surgeon from Malaysia. Dr. Mahendra Kuchatkar is from Goa and he is upcoming president of Foot and Ankle Society of India. Dr. Nikesh, our own person from Gujarat, is an immediate past president of Indian Foot and Ankle Society. So let me start ball rolling. Here is a patient, female, 42, who complains of pain in heel from 5 months. And this patient comes to you, Dr. Chua, in your outdoor. What important point you're going to ask in the history and what is the significance of asking this point is what I want to know from you. Dr. Chua, please.
Yes, you need to ask when is the patient having the pain and then what time of the day they are having the pain. Whether early in the morning, first step, when he wake up from the bed or after walking for some time. And we want to know also any recent history of any weight gain or any history of changing any new shoe wear or any
Excuse me,
yes,
Dr. Chua.
yes.
Suppose patient complains of pain at the first step in the morning. What would you infer?
Yes, this may be a case like a plantar fasciitis, where when at night they are resting, and then when they wake up, the first step, when the calf is very tight, and then causing the pain over the plantar heel.
Okay. And then you said that any change in the activity, what would it mean to you?
Yes, sometimes the patient may say, oh yeah, I increased the activity of running because after seeing a cardiologist, he asked to do more exercise, and suddenly the increased duration of exercise, then they may start have pain. Or they wear a pair of shoe which is not so suitable, and then they increase the pain. Or they change their job to a more prolonged standing type of activity, which also may aggravate the pain.
Dr. Mark, what else would you ask to this patient who is coming to you with a history of 5 months of heel pain?
I would be interested to know, first of all, good evening or hello, delegates. What I would like to know is if the patient has also a history, any history of inflammatory disease, inflammatory arthritis, or some inflammatory problem, because that is one of the unusual differential diagnoses. The other area that one must consider are back problems, whether they have any back pain or radiation, sciatic pain, radiating down to the leg. And then beyond that, if they are an athlete, if they are regular runners and have changed their running pattern, which may indicate a potential risk for stress fracture.
Dr. Mahendra,
Yeah.
how would you differentiate a pain which is originating from the spine and pain which is originating from the heel by the history?
Well, the pain that is coming from the spine is usually a radiating pain, and the nature of pain is such that it is related to the spinal movement, especially extension of the spine will cause rise to lower back pain and then giving rise to radiating pain to the heel. Whereas the heel pain per se is a very localized pain, which is fixed just under the heel. So patient will just point out straight to the heel, and whereas instead of spine pain, they're going to give a different pattern of presentation. They will say that it starts from the buttocks, goes down to my legs, and it comes on usually on the extension movement, like trying to get up from a sitting position, or turning a position, or sitting for too long. But in the heel pain, it's located under the heel. So I think the patient's history itself is going to be suggestive of location of the pain.
Thank you. Dr. Mark, what do you infer when patient says that patient has history of multiple other joint pains in the body? Is that something related to heel also?
Well, this is usually related to an inflammatory condition. It's important to appreciate that if the patient presents with both feet being painful at the same time, that one should consider or think about whether there is an inflammatory disease. The most likely is psoriatic arthritis and other seronegative arthritis. It's rare to have rheumatoid arthritis, but when they have multiple joints affected, it's important to think about an inflammatory disease.
Dr. Nikesh, would you like to add something more in the history, and with every point, stratify your logic for asking that?
Most of the points are covered, but I would like to ask for the occupational history regarding the occupation of the patient, the amount of the time which is spent on weight bearing during working hours, and the vibration, whether it is there at the workplace. Also, I would like to ask the history about previous treatment with any history of steroid injection or not. And also recreation history is also very important, like patient, it is already covered as the history, but like when patient has started some dance practice or something. And also if there is a bilateral or unilateral pain, which is also very important. If it is bilateral, it is suggestive of any systemic pathology. And also I would like to have the history regarding where is the maximum pain, whether it is at the heel strike or whether it is at the toe off. If it is at the heel strike, then it is suggestive of fat pad atrophy or stress fracture. But if it is at the toe off, then it is suggestive of plantar fascia lesion. These are the few important points which I would like to have in the history.
There are three times during the day when the patient will commonly experience the plantar fasciitis pain. And you correctly mentioned the first step in the morning, but the other times are when the patient gets out of a chair during the day after they've been sitting, or if they've been driving a car or sitting on a train or a tram and they go to start walking, and that's when they get the pain. So if they describe each one of those, that's a strong indication of plantar fasciitis.
Dr. Navin, would you wish to add anything in the history taking?
I think everything is added very well.
Yeah. So
can I mention about one thing about basically the history of any comorbidities like hypothyroidism, basically, so that patient, because this patient are going to show history of weight gain, and so history of hypothyroidism is one thing that needs to be asked in these patients.
Very well said. So to just quickly summarize, as Dr. Nikesh said, unilateral or bilateral, bilateral pain almost always suggests some systemic pathology. Unilateral pain suggests something into the heel per se. Occupation and level of activity, where is the pain? Most important, whether it is medial, lateral, posterior, or plantar. Dr. Nikesh, if patient comes with the pointing pain at lateral aspect of the heel, what do you infer from the history?
The lateral aspect of the heel, mostly it is suggestive of either any varus deformity in the heel which causes increased weight bearing on the lateral aspect of the heel. So that could be the cause of the any varus deformity may cause the pain on the lateral aspect of the heel because of the increased weight bearing.
Dr. Chua, Dr. Chua, any other reason for lateral sided heel pain you have encountered in your practice?
Yes, you may need to know any history of ankle sprain or injury, and then you may need to check also whether there is a sural nerve problem, which may causing the problem as well. Yeah.
And sometimes the patients who have pressure over Baxter's nerve or nerve to abductor digiti minimi or first branch of lateral plantar nerve, because that nerve supplies to abductor digiti minimi on a lateral aspect of the heel, patients do complain of pain there because of the pressure over the nerve. Okay, night pains, pain at heel strike or toe are very well described by Dr. Nikesh. Character of the pain, radiation of the pain, aggravating relieving factors, history of trauma, pain in other joints, recent change in activity, recent weight gain. Weight bearing time is one very important thing. We always are worried about weight gained by the patient, but the weight bearing time patient is spending is equally important, which we should be asking. Obviously, family history, personal history, and treatments taken. So then we come to the clinical examination. Dr. Mark, what important points you are going to see in the inspection and palpation for a case who is coming with the history of pain in heel from 5 months?
Well, I think the first thing is to have a general look at the patient and assess the patient, whether they have a normal weight or they're overweight. And then moving down to the legs, do they have any abnormal foot posture, whether they have pes planus, pes cavus, because that can point you into a direction. Following this, you need to look at the foot pattern and the way the patient walks, whether they walk with pain or whether they walk with a limp, and how the foot strikes the ground, whether if they have varus heel, valgus heel, and how that affects them when they weight bear. Then you want to look at the shoe wear to make sure that to see how the shoe wear pattern is. Once we've identified that, then you can move on to inspection of the actual foot. And you ask the patient to point where they have the tenderness. And so I see a picture of that here. Did you want to show that one,
No,
Rajiv?
no, I'm going to show it after the discussion.
Okay, so in a patient with plantar fasciitis, the tenderness is usually over the plantar medial side of the heel. And this is often acutely tender. The other features that one would look at this point, is there any areas of tenderness in other areas, such as if there is fat pad atrophy or a stress fracture, or if it's Achilles tendon. All of these have tenderness which is specific to that area. And I think you can see now on the screen the different locations, and this can be quite a helpful guide, and you just need to know your surface anatomy to have a good appreciation. So either it's plantar fasciitis or it's something else. And so you should be guided a little bit by the history.
Dr.
The
Chua,
other,
yeah, sorry, Mark, go ahead, please.
Raju bhai, there is a question from the audience. Anybody can say differential diagnosis between local heel pain and pain coming from the spine. Any mimicking condition from the spine? Do you need to see for the spine condition also?
So Dr. Mahendra already answered this question, but probably if the question is from the delegate who has joined late, Dr. Mahendra, can you answer this question?
Yes, I think it is clinically when the patient in the history itself, the patient is going to point towards local back pain, and the pattern he's going to show with his palm that he has a pain coming down his back, radiating towards the buttocks, and then going down to the heel. Whereas the patient with the plantar fasciitis will show a localized pain in the heel. And once you examine the patient, you do an active SLR, you do local spine examination and the heel examination. I think that is enough to differentiate between spine pain and the heel pain.
I think the question is there will be pain, but there won't be any tenderness at the local site. Is it true?
Perfect.
Yes, absolutely right.
It's the pain, but no tenderness.
Absolutely.
Pain
right.
not
Referred
correlating
pain
with the
is-
tenderness.
And the
referred pain
spinal,
is very diffuse, whereas the heel pain is very, very specific, located at one point.
and spinal pain would be into the dermatome or the neurotome of that particular disc through which the pain is coming.
But many times there is no backache, only the referred pain is.
Yes.
Then it becomes a problem.
Yes.
So in the examination, Dr. Navin, would you wish to add something?
You have to check for the medial side, that is for tarsal tunnel syndrome.
Great point. Dr. Chua, would you want to add something into the clinical examination for a case of plantar fasciitis?
Yeah, clinical examination, I always will check the calf muscle, whether there is a gastrocnemius tightness. Because one of the important issue on the heel pain, whether it's tendon Achilles or plantar fasciitis, a calf muscle, especially the gastrocnemius tightness, is very important. So I will do a silver squat test for this. Yeah.
Dr. Nikesh,
Yes, sir.
any special test you will perform for differential diagnosis of heel pain? One test Dr. Chua mentioned is a silver squat test for doing the deformity or the tightness of the tendo Achilles. Any other special test you would wish to do?
Dorsiflexion of the great toe, it may give rise to the pain because of the stretching of the plantar fasciitis. That is one of the tests. And the local tenderness, of course, by pressing and knowing where is the exact pain. So that can also give rise to the location and the etiology of the pain.
Mahendra,
Also, yeah, to differentiate tarsal tunnel, as Dr. Navin Bhai rightly said, the
Another is
eversion,
the another is
eversion and
the
dorsiflexion of the ankle to know the tarsal tunnel syndrome. So that is also one of the tests one can do.
Nikesh,
another
please, Nikesh,
is
please,
the
somewhere the background TV is working somewhere. In
No.
some
Oh,
of
it's
the
in my house, I think.
okay.
Give me a sec.
So, Mahendra, any other important clinical tests for differential diagnosis you want to describe?
yeah. Another thing is the calcaneal squeeze test, where you can apply pressure on both the sides.
I'll just
And-
move rooms.
Yeah, go ahead, Mahendra.
Yeah, so calcaneal squeeze test helps to differentiate from more like
No,
a
no.
stress fracture, or even in a very localized osteoporosis. It's more of a diffuse calcaneal pain. Will be more predominant with the calcaneal squeeze test.
So there are certain special tests for differential diagnosis of plantar heel pain. As one test described by Dr. Chua was a silver squid test. A calcaneal squeeze test is what Dr. Mahendra described. And there is a tarsal tunnel stretch test where you are doing that test into the extension of the knee with complete dorsiflexion of the ankle and eversion of the ankle and dorsiflexion of all the toes. If this provokes pain at the level of tarsal tunnel, that means this is the
Raju, demand is, do you have that video of that test?
yes. I am showing that. I am showing.
Okay,
See,
lovely.
another important examination is the examination of the soft spot of the heel. Now, what is soft spot of the heel? It is the place where neurovasculars they enter into the plantar region of the foot underneath the deep fascia of abductor hallucis longus. So if that finger, the point, it is called soft spot. When you start palpating calcaneus from posterior to anterior, suddenly a bony tenderness would give way. And that is called soft spot of the heel. If that point is tender, that means the plantar heel pain is originating from compression of neurovascular structures underneath the deep fascia of abductor hallucis. And this is the neuritic origin of the plantar heel pain. So soft spot of the heel must be appreciated and must be, I'm running a video how to examine the soft spot. So that is a soft spot. So when you start evaluating from the posterior aspect, I am again running the video. Suddenly your thumb would give way, bony pressure would go, bony feeling would go give way. This is the soft spot of the heel. So this one examination is important. And some special test, yes, calcaneus squeeze test. Dr. Mahendra did spoke about that. And this is the TTS stage test. Dorsiflexion, eversion of the ankle and stretching of all the toes into extension. If it mimics pain at the level of tarsal tunnel, that means it is a very sensitive test for tarsal tunnel compression. So, any other point, panelists, we are missing?
Can I mention one thing, Rajiv bhai? I think the patient in a tarsal tunnel typically describes a burning pain along the medial side of the foot and more at night. So a night pain and a burning nature of the pain should also suspect a TTS compression.
Yeah.
Yes.
Dr. Chua?
Yeah. If you query about the tarsal tunnel, then you may need to do a tenial sign where you tap, follow the course of the posterior tibial nerve, and then they may tell you there is a tingling sensation that go into the big toe. Then you can be sure that this may be due to the nerve pain rather than specific to the facial pain or posterior heel pain.
Yes. So yes, Dr. Nikesh, you want to add something?
Yeah, the deformities of the foot like planovalgus foot or cavus foot should be looked for specifically because that is the one of the etiology of the heel pain. Also the fullness or the bursitis of some sort of should be looked for. And the most important is one has to examine the shoe of the patient and the wear and tear of the shoe from the outer sole, which can also give a very good clue regarding the management and the habits of the patient. So
Great.
I would like to examine the shoe also and the insole also, the insole of the shoe which patient is wearing.
There is an input from the audience also. What is the observation of the patient walking? He'll be walking on the lateral border of the foot and not putting the weight on the medial border. Will you examine that walking of the patient? How
Mostly
he walks?
plantar fasciitis patients will have antalgic gait rather than putting weight on the lateral border of the foot.
Right.
So mostly it will be antalgic gait rather than the lateral border weight bearing gait.
And Rajubi, there is a
Yes.
question from Dr. Addepalli Srinivas Rao from Vijayawada. Any specific test for now to ADQ help in that particular muscle you described?
Yeah. So as I said, when you elicit the tenderness at the level of soft spot, that is suggestive of pressure over nerve to abductor digiti quinti. It is also called as Baxter's nerve. It is also called as first branch of lateral plantar nerve. It is also called as nerve to abductor digiti minimi. So
Okay.
neuritic pain you will be able to differentiate by doing a soft spot tenderness evaluation and your history part. Dr. Chua want to add something?
Yeah, I want to add the gait. When patient, you need to look for any pronation gait where the flat feet and also the press planus, there's a correlation between the plantar heel pain. So if there is a flat feet or a pronation gait, then maybe some kind of shoe wear modification will be helpful for the patient.
So typically, when a foot and ankle patient enters in your OPD, that patient comes walking. One, that patient comes with the trousers lifted above the knee. Two, and that patient comes with the footwear and orthotics on. These 3 points are important. And clinician should examine this patient in a sitting position, in a standing position, and in a walking position. So all these 3 things are important. So by and large, we have covered the differential diagnosis and diagnosis of plantar heel pain. Now, Dr. Mark, 5 months of plantar heel pain, how would you treat a case of plantar heel pain who is coming to you for the first time in the outdoor?
Well, the first time, I think the most important thing is to confirm a diagnosis, because the treatment will take time to respond. And so you need to have the correct diagnosis first. So for the clinical diagnosis, I think the history and examination should get you most of the way. But in Australia, in my practice, I would regularly perform an X-ray as well as an ultrasound of the plantar fascia. The findings that I would be looking for on the X-ray, generally one sees a fairly normal X-ray. You might see a plantar heel spur, but that would only be relevant if it was very large. But what particularly interests me is the thickness of the plantar fascia on the ultrasound. The normal plantar fascia thickness is 3.5 millimeters. And if the plantar fascia is thickened beyond 5 millimeters with some delamination, that would then confirm the diagnosis, particularly if the opposite side was normal.
So Mark, sorry to disturb you, Mark, interrupt you. Do you do your ultrasounds on your own, or you rely on your sonologist?
Well, I don't have an ultrasound machine, but I rely on the my friendly ultrasonographer. I appreciate that that is not a universal examination or universal test, but that is something that I use in my own practice.
So what hematological investigations you commonly order for these patients?
If I'm confident and the ultrasound is normal, I generally do not do any hematological examination unless another diagnosis is considered. If
Dr.
I'm
Chua,
excluding an inflammatory disease.
Dr. Chua, what are those indications where you advise MRI for plantar heel pain, or you don't?
I usually don't do a MRI unless the patient after the standard treatment on a non-operative is not resolved, or some patient are very worried that they wanted the MRI, but usually I'm not performing the MRI.
So what is your standard conservative treatment for plantar heel pain?
Yes,
Dr.
my
Chua?
treatment will be very important to treating. Once is ask them to decrease their weight, which is a bit difficult. And if the patient have a flat feet or pronation gait, then I will give them a medial arch support, even at home, and the sender that they need to walk on the medial arch. And then most importantly is the calf stretching exercise, which I have a special board for them, about 25 degree of slanting board, and then they can stretch on the calf for 5 to 10 minutes, 2 times a day. This is very, very important. And then I will give them a short duration of NSAID, either Acoxia or a Cerebrex for about 10 days. It's only 10 days. Then I will see them in 3 weeks. They should tell me the pain is decreased, and then I will just ask them no more medicine and continue calf stretching exercise.
Dr. Mahendra, what is your conservative protocol?
I think the most important thing for these patients is to tell them that this pain is going to take a long time to go. So we have to first assure the patient that everything is fine. Weight loss is going to take some time and a lot of effort. And this is going to be a long drawn battle because usually the patients expect this pain to go away in a few weeks. It doesn't. So what Dr. Chua said is that weight loss is extremely important, giving a UCLA type of orthosis with a medial arch support and an inner heel wedge so that you deload the plantar fascia, preventing it from going into a planar valgus situation. And also put them on an eccentric stretching program. So the calf eccentric stretching exercises. And sometimes they may use a night splint if it works, but does not work in all the patients. And if all these modalities don't work, then I would like to opt for more non-invasive,
So,
like probably like a
just a
yes,
minute, Mahendra, why do
yeah.
you want to give night splint? What is the logic of giving night splint?
So it basically prevents the calf muscle from basically going into contracture. The plantar fascia becomes tight over the night, and then the first step in the morning when they keep down, that helps to reduce the pain that occurs in the early morning. So night splint is basically to prevent the fascia from becoming tight.
So could you describe how it is given, like any position of the ankle?
It's about 5 degrees of dorsiflexion from the neutral, and sometimes these patients don't tolerate them. So in that case, you also tell them to sleep with their feet touching the foot end of the bed. That is another way of preventing this contraction.
Dr. Navin, what is your conservative protocol for management of plantar heel pain?
The simple exercise of stretching of the plantar fascia and hot and cold uh, fomentation that we routinely do for initial stage.
Dr. Nikesh, your protocol for conservative management?
For first 3 to 6 weeks, what we give is ask the patient to wear the soft slippers, or we can give the silicone insole for the cushioning of the heel. The plantar fascia stretching and the calf stretching exercises are must, and that helps a lot. Also, we ask the history regarding the activity of the patient and ask them to decrease the weight bearing activity like morning walking or some jogging or dancing, that one has to stop. Also, we advise regarding the application of ice on the affected part to reduce the inflammation. And also we can teach them proper exercise so that normally they they are not aware of how to do the exercise. So that demonstration of the exercise is very important for them. And we always advise them, and we always convince them that the treatment, as Dr. Mahendra rightly said, that treatment is going to take a long time. So that sensitization of the patient is also very important for cooperation during the treatment, so that they don't discontinue the treatment in between, and the whatever advantage is gain is lost. Also,
My
we can give them some stretching device, like stretching on a roller or stretching device, to maintain the flexibility of the plantar fascia. And I also advise them to use some wooden block while sitting on the chair or on a sofa at home, or while watching the television. I always ask them to have a wooden block wherein they can put their forefoot, so that the plantar fascia and the ankle is stretched in a dorsiflexion position for some time, and that also relieves the pain to a large extent. So that use of some like book or some wooden block or something which they put under their toes, so that the ankle remains in the dorsiflexion.
So what I am given to understand that majority of the panelists would first start with the conservative treatment. Now my question to every panelist, starting from Mark, would you give a local steroid injection for a case of plantar fasciitis? Starting with Mark. Mark, would you give local injection, steroid injection? Yes. Why? No. Why?
Well, I think it's part of the armory of your treatment. So I will extend along from the conservative treatment and say that I always give the patient 3 things to do when they have a conservative treatment. So that of the 7 or 8 different options that we have available, they've usually tried 1 or 2 by the time they come and see you. So I make sure that they have stretching, orthotics, anti-inflammatories. That's 3 things. Or stretching, weight loss, changing footwear. 3 things. And then I would not give I would not give the patient a cortisone injection on their first visit, because I think simple methods are the best methods until you identify if the patient is responding to treatment. Now, so if they are not responding to treatment and you feel that there is an inflammatory component, I personally think a cortisone injection is a good option when it's done correctly. I used to do it myself, but these days I get an ultrasound guided injection.
Okay.
So I do use it, but not for everybody.
No.
It's not many.
Dr. Chua.
Yes, I think 90 to 95% of patients respond to the good stretching exercise at home, and only the 5% of patients they come after 3 weeks or 6 weeks without any response, or they say there's no response at all, not even 10% of you get better. Then I may give them a dose of the steroid injection. Yes.
Okay. Dr. Mahendra.
Yes, so I used to use a lot of steroids before understanding the mechanics of the plantar fasciitis. I think a proper counseling of the patient here makes a lot of difference, because you have to tell the patient that you have to treat the problem and not the pain. Because if you treat the pain, the problem still remains. So if you do a good counseling and tell the patient that the injection is an option, but it is not going to give you a cure, but just give it to fix your pain for some time, then the patient himself or herself is going to opt for a more conservative methodology. So I think a good counseling will help the patient to go away from a steroid. And in the last couple of years, it's just about 5 to 10% of my patients who would, force me to give an injection, but I would stay away from that as much as possible.
Dr. Mahendra. Dr. Nikesh.
I always wait for 6 to 8 weeks and have the effect of plantar fascia stretching exercise and physical therapy. But after that, if patient is not relieved, then one is obliged to do something and offer them something. And at that point of time, we go for local steroid injection. Of course, I don't use ultrasound because it's not freely and readily available. So we injected the insertion of the plantar fascia remaining just superficial to the plantar fascia to avoid the plantar fascia rupture, because that is one of the big risks of injecting the plantar fascia.
So, Dr. Navin, do you
Yes,
inject?
yes, I inject, but not that much frequently. What if even after the injection, many times we get the patient even after the injection, I do something new, but whether it is reported in the literature or it's right or not, I don't know. I do with the needle multiple punctures in that medial side of the plantar fascia attachments, and that releases somewhat plantar fascia, and that gets relieved in the cases where it is not relieved by many therapies has been done. So that I don't know exactly what is the opinion of the other faculties.
So needling has been described as a part of treatment of plantar fasciitis. So far as I am concerned, I usually give posterior tibial nerve block because I want to block the pain gateway for about 3 weeks. And if at all you want to inject a local steroid, look at these pictures. Don't inject underneath the plantar fascia. Otherwise, patient would have fat pad atrophy. If
Right.
you inject into the fascia, as Dr. Nikesway said, this fascia would get ruptured. You have to go anterior to the bone and above the plantar fascia into this space to inject, so that you are not damaged, you're not getting a fat pad atrophy or a rupture of plantar fascia. As Dr. Mark said, it would be always better to go with the ultrasound guidance. If it is not available, Dr. Nikesway, you could go with an image guidance, putting the limb into dead lateral position. Uh, okay, Dr. Chua, if your modality, conservative modality fails,
Yeah.
then or for how long do you try your conservative modalities?
I will try at least 4 to 6 months though.
And
Yeah.
suppose it fails, then what next?
If you fail, then for my practice, I will usually counsel them for endoscopic plantar fascial release.
How do you do
But before,
endoscopic plantar fascia release?
yeah, we do a two-porter infra plantar fascia, and then just to release the fascia without removing the spur.
Okay, so you completely release the fascia?
No, we only reduce about 30%.
Okay.
Yeah, on the medial side.
And when you are doing endoscopic plantar fascia release, what are the chances of injury to the nerves?
Uh, there is a very little chance. Never happened before in my practice. Yeah.
So what is your post-op protocol when you are doing endoscopic release of plantar fascia?
Yeah, for 2 weeks, they shouldn't do anything because waiting for the wound to heal. And after the wound heal in 2 weeks, then I will start them on the mild weight bearing as tolerated. So most of the patient, it can tell you that after about 6 weeks, the pain will totally go away. And then slowly the visual analog score will be slowly released from the 6 week onward. Yeah.
Dr. Navin Bhai,
Yes,
after failure of conservative modalities for 4 to 6 months, what is next? What do you do next?
the, the injection I said, and then the needling,
Okay.
and the cutting of the that tight plantar fascia with the needles, multiple puncture to release the tension. That I do
Mark,
routinely.
Mark, how
In
long
the
do you
first,
try with the conservative modalities, and failing that, what is next in your books?
well, I like, I don't see this written down, but I like to just to try to break up the patients into what I would describe as chronic resolving plantar fasciitis and chronic recalcitrant plantar fasciitis. So there is, and your job in the first 12 months is to try to get the patient to the resolving group. So that's where the pain is generally manageable and improving slowly. And in those cases, I just continue with whatever conservative treatment is necessary. But there is a very small group which don't respond to treatments very well, and they're in a lot of pain and their life is miserable, and they're the ones that maybe move on to the more interventional bracket after 12 months or so. So it does depend, and then there are other patient groups such as sports people that we may be a little bit more aggressive as well. So it depends is my answer.
So by 12 months, what surgical procedures you would do?
I've always done endoscopic plantar fasciitis release.
Oh,
I taught Chua.
yeah.
And
Okay.
same procedure, and yes, the results are very largely reliable with relief of heel pain. So it's a good, I think it's a good procedure in the right circumstance, but have to be very careful with the rehabilitation, because if they do too much too early, they can get lateral overload or metatarsalgia, which can be difficult if it takes hold. So one has to be cautious and counsel the patient correctly, and they have to go slow.
Mark, I have one or two reservations with this endoscopic method. See, many times this plantar heel pain is because of neuritic plus a facial etiology. Both are combined. So then it is mandatory to decompress the nerve to abductor digiti minimi, which is passing underneath the deep fascia of abductor hallucis longus. So how can you do that with endoscope?
Well, I do respect that there are patients with that condition. And in the first 5 years of my practice, that is exactly what I would do. I would make sure I did an open release and also a tarsal tunnel and Baxter's nerve release always when I did the surgery. But strangely enough, since I've done the endoscopic release, that hasn't really been, I haven't wished that I had gone back and done the other surgery. So there's something about the endoscopic release that covers most of those problems, and I'm not sure why, but it hasn't been an issue.
Dr. Mahendra, failure of conservative modalities for 6 months, 12 months, what is your bottom line and what do you do next?
So the other three modalities that we could try if you have the access is, one is you can use extracorporeal shockwave lithotripsy, like a local shock therapy, or you can use radiofrequency ablation. And the third is, instead of giving a local steroid, you can try a PPRP injections. So try these three things before giving the option of a surgery.
So your experience about PRP, does it work?
It's a mixed response. I mean, sometimes, you might, if you really believe in it, you feel that the patients do respond. Generally in literature, it's about a 50-50 chance of the patient responding. So more of a placebo rather than anything else, I suppose.
Dr. Chua, have you used PRP for plantar heel pain?
Yeah, I occasionally use PRP. I not use this regularly for the reason being, PRP in our country is expensive. For example, it costs about 2,000 ringgit compared to 50 ringgit on a steroid injection, right? First. Second is you need to counsel patient. If you use steroid injection, then the pain will go away in 1 or 2 days. But if you put PRP, then the pain may be increased for the next 1 week before the pain is decreased. And normally they take about 2 to 3 weeks to respond. And for a patient on steroid, they may recur like about 6 months, most of them. And for PRP, they may take a longer time to recur if they are recur like about 9 months. Because the etiology is more on degeneration. So theoretically, PRP will help, but practically they are just almost the same like steroid injection.
Mark, do you use extracorporeal shockwave therapy or radiofrequency coablation?
I use
Or PRP?
I do use shockwave therapy, it's a third line treatment because it is invasive, or it is a little bit painful for the patient, because most of the shockwave machines that we have are ones that are handheld, and they're not, the patient doesn't have an anesthetic for it. And also they need a number of treatments, not just one treatment. So there's a cost associated with that. So I generally hold it back, and for patients that aren't responding to the standard treatments, but aren't severe enough to have surgery.
In PRP?
It is used, but it's not something that I use for this problem. I haven't seen much evidence, but I do hear anecdotally that there are subgroups of patients which respond well. And also there was a move, there was some people would do radio frequency ablation as well, but that isn't really done much now that I know of.
Dr. Nikes, would you want to add something in the treatment protocol you follow?
Oh, I mean, we don't have access to extracorporeal shockwave therapy. That special machine is not available. And so
machine is available. I'm using that. You know that.
I don't have available. I don't. I will send patients to you. And regarding radio frequency, also I send it to Dr. Rajiv Shah.
So
I prefer surgery than those machines, because I don't have those machines. Simple.
Question to everybody in the panel: how many of you would do, together with this endoscopic or an open surgery or plantar fascia release, you would add gastrocnemius recession or lengthening of the tendon Achilles? Mark?
I never do it for plantar fasciitis.
Chua?
Yeah,
But I know
seldom
that
do
some
it.
people do.
Yeah.
Yeah. Dr. Chua?
No, I seldom do together as well.
And Mahendra?
Yeah, you would try to do this only on clinical examination if you really find a contracture, and if your patient is not responding, only then I would do a recession, not on the routine patient.
Dr. Nikesh?
Yeah, if there is a silver square test is positive, then only I do gastric release, not in every case.
So same here, there are a group of doctors who just do gastrocnemius recession release for patient of plantar fasciitis, like surgeons remove the appendix for pain in abdomen. But my protocol is to go in for the open surgery, failing conservative therapy for about 12 months. I do try with shockwave, I do try with radio frequency ablation, and then at the open surgery, I would add gastrocnemius lengthening, provided there is a kind of tightness of the gastrocnemius. This is the picture of night splint, which is to be given to the patient for reduction of first step in the morning pain. These are some pictures of some exercises. And this cane rolling, as Dr. Nikes was describing, something under the foot to stretch out the plantar fascia is a good activity. And this is what is important. I ask my patient to prepare a board and keep that board in the bedroom as well as kitchen, that my heel pain is going to vanish. It may take some time. And steroids, I like to give posterior tibial nerve block with Marcaine, so that it lasts long for control of the gait therapy. And then sometimes I do give Biloni walking cast, and that's a shockwave machine which we use, and that is a Topaz radio frequency, Goblation, and PRP again is a big question mark. I have not used PRP. And failing all this thing for 12 months, surgical management open would be in form of partial medial plantar fascia release, decompression of the first branch of the lateral plantar nerve if there is a neurological element, and spur excision is mostly not required. Sometimes it is guided by the prior opinions. When patient comes to you after 1.5 years with 3-4 X-rays, where surgeons have marked the spurs, you sometimes are obliged to do open release of the spur. So coming to the case we were discussing, the case had bilateral lateral heel pain. She was a teacher by profession. She had hypothyroidism, as Dr. Mahendra was mentioning. She was a teacher, so used to stand for a long time, and a bilateral heel pain. And then she had multiple pain sites in the body, lateral epicondylitis, shoulder pains, supraspinous tendinitis, CMC joints of both the thumbs, and fibromyalgia all across the body. She had a tender soft spot of the heel. She had heel valgus and a flat feet. And she had a tight tarsal tunnel stretch test positive. So for me, diagnosis was neuritic plantar heel pain with hypothyroidism with flat foot and heel valgus. And we corrected all these things. And then she went on to improving.
Sir,
So,
before you go to the second case, there are a lot of questions.
please,
So
we will want to take the questions because now we are moving to some other.
yeah, I know. That's why. How
Please.
long to give the night splint and exact location of the posterior tibial nerve block? Any video on surgery?
Okay. Presently, I don't have any video onto posterior tibial nerve block, but posterior tibial nerve can be located exactly in the center of the posterior border of the medial malleolus and anterior border of the medial part of tendoachilles. Exactly, it is in the center. You can palpate your neurovascular structures, and then you pass your needle right up to the bone, aspirate, and then inject about 10 to 20 cc of a combination of xylocaine and sensorcaine. And that is how you give posterior tibial now. With respect to night splint, Dr. Mahendra, how long would you give night splint to the patient?
So it all depends on how long the patient has been suffering. The longer the patient has been suffering, I think the duration of that heel pain. So night splint is just to make the patient aware that he is also being treated 24/7. And so just night splint by itself is not a magic wand. So it is just a methodology to keep the patient focused on the treatment.
Okay. Next question, Navin bhai.
And the next, any role of laser?
Laser.
Yeah.
Dr. Nikesh bhai, would you take up this question?
Yes. Actually the laser which is used is effective as good as an infrared therapy. So there is no special advantage of laser except the marketing by the physiotherapist and the charges which they take. So it is same as any infrared therapy. So no use of laser is beneficial.
So it has no more benefit than the other physiotherapy, which are cheaper and easily accessible. Dr. Navin bhai, next question.
Raju, the question is, what is the cost of your extracorporeal therapy machine?
Okay, this extracorporeal therapy, initially we used to use the kidney lithotripter, which is not essentially meant for this. But the extracorporeal shock therapy machine which comes, it ranges from 5 lakhs to 6 lakhs in the cost. And now there are cheaper machines also at costing at 4.5 lakhs.
And do you have the video of you are doing medial release of the plantar fascia and relieving that now?
Yeah.
Can you show that video? Is it available?
It
may be shown later on, no issue, but that is required. That people have asked. And another question is, many times, what percentage of the patients are going this release surgery in your practice? Hello, Raju bhai. What is the percentage of the patients which undergo this release surgery in your practice? Monthly or yearly or whatever maybe.
Mark, could you answer this? How many percentage of your cases go for this kind of endoscopic plantar fascia release?
For me?
Yeah.
Yes.
Oh, so it depends on the practice. My practice, most patients who come to see me have already had plantar fasciitis for 12 months. So they're already a little bit more further down the line. So the percentage is probably a bit higher than some, but probably 30% of those, because they've already been treated with multiple treatments, because they've usually had all the treatments, and I'm like the end stage referral. But for a normal office practice, I think really it's really probably 5% of patients would require treatment for plantar fasciitis.
Yes.
Dr.
Okay,
Chua,
then in okay.
Dr. Chua, your number
Yeah.
of percentage of surgical interventions?
They need less than 5%.
Okay.
So coming to Navin bhai, coming to
and the next follow-up question is, how many patients worsen after the surgery?
okay,
Is
that's
there
a
an experience
fantastic
of
question.
worsening after the surgery?
Yes, fantastic question. So now coming to my number of surgical patients in my long practice of foot and ankle orthopedics, I must not have operated more than 60-65 cases of plantar fasciitis. Whenever I undertake the surgery, no patient has ever undergone surgical intervention beyond failure of conservative modalities for 18 months in my series. Very important to inform these patients that the area into which we are going through for this surgical intervention is full of anomalies and nerves. So I inform my patient that there would be a neuritic pain lasting from 6 weeks to 6 to 9 months. I also inform patient that the recovery might take up to 9 months. But if a given sure shot indicated case you're doing this, there won't be deterioration. Only thing that some patients might take very, very long time to improve, and very few might not improve.
Then now the follow-up question is, many times patient fails to come in the follow-up, and when it comes for the another problem, when you ask that, that patient is relieved without taking any treatment.
Oh, that's absolutely the right thing. Absolutely the right thing. And that is why the first thing, which as Dr. Mahendra mentioned rightly, that you must convince patient that your pain is going to go away. And that's why I ask patient to prepare a board and keep in our bedroom as well as in kitchen, that your pain is going to go away.
Okay, the Dr. R.M. Chandak, probably it is written RMC capital. Which is the best NSAID which is effective in long term?
Okay, Dr. Chua, you said you use celecoxib?
Yes, I only use the celecoxib or acoxia for just 10 days. They shouldn't take more than 10 days. If they need the NSAID more than 10 days or 2 weeks or so, something is wrong.
Dr. Mahendra, what NSAIDs you use?
So I would tell the patient, as far as pain NSAID is concerned, especially about if they are 50 plus with comorbidities, I would just put them on the tramadol paracetamol combination. Please do not use ibuprofen and diclofenac for a long time, because NSAIDs, any NSAID is dangerous. I mean, it may cure the pain for some time, but it's never going to fix the problem. So I think counseling the patient as well as painkillers is extremely important.
Dr. Nikesh, what NSAIDs you use?
Normally, I go for itracoxib paracetamol combination, and that sounds good. The problem with the tramadol is, of course, constipation in old-aged patients, the middle-aged patients. So, but of course, it has its own benefits regarding the renal issues. But itracoxib and paracetamol definitely works better because it has very good anti-inflammatory and analgesic properties.
So for me, I extensively use itracoxib paracetamol. Tramadol, yes, but tramadol has a very important kind of activity onto the inflammation. So I reserve it for the patients who got renal issues. I use quite a bit of neurotropics because they work very well. And I also use anti-gout medications when the patient has got problem of gout. Next question, Navin bhai, please.
And the next question is from Dr. Girish Motwani, Nagpur, again a foot and ankle surgeon. Role of steroid injection in Baxter nerve compression.
Girish, I have not used steroids for pain which is originated from the nerve also. I would wish to use a posterior tibial nerve block, but in a given situation where you are very, very confident that your pain is originating from Baxter's nerve, you may try a local steroid injection at that place, and that may work. What is the experience of other panelists? Use of local steroid injection for a pain which is generated out of compression of Baxter's nerve. Mark?
For me, it's a very, very rare diagnosis. And I don't know whether we just don't see it or I'm missing it a lot. But I think I've probably seen one or two in my career. So I'm not very experienced,
Dr.
I'm
Chuan?
afraid.
Yeah,
Dr.
not frequently we use, but if there's a sural nerve, yeah, sometimes I use for sural nerve.
Okay. Dr. Nikesh and Dr. Mahendra?
Yeah, I haven't used a steroid for a PTS problem or a Baxter nerve problem. I'm not so good at injecting it exactly around the nerve.
So what I feel is the basically putting a diagnosis with a firm diagnosis that this is a pain generating from the compression of the Baxter's nerve. That itself is an issue of the treatment. So if we are not confident on the etiology of the ailment, then the putting a steroid there is not going to serve any purpose. So many times, I mean, the diagnosis itself is an issue. So I have not come across this type of diagnosis, at least. Very rare. Very rare.
Navin bhai, do you want me to
Yes.
show the video?
Yes, you show the video. In between, I will ask the question.
Okay.
You find out the video. The role of local nitroglycerin patch to increase the blood supply. This is the suggestion given by Dr. Tejas Gandhi from Ahmedabad.
Okay.
If anybody has
So
experience
before that,
nitroglycerin patch.
before that, can you see this?
Yeah, we can see it. We can see it. We can see it
Yeah.
very well.
So this is a video of surgery for heel pain where I do partial medial
Just
plantar
you're not open up the video, I think.
No, I've opened. A video is
No,
running.
it is there. It is there. It is not with us. So just share the desktop, not your that screen. Share the desktop. Share the desktop. Stop sharing and go again. Stop sharing and go again, and select the screen where all the videos are seen. All we are seen. That select that screen. That is a very easy indicator to select the screen.
Okay.
Yes.
Are you
Fantastic.
seeing that?
Yes. Now it is okay. Just click that. Click that.
I clicked that. Okay. Are you seeing the video?
No, we are not seeing. Again, we are not seeing. You are not selected the video part. You are not selected the desktop. You are selecting one of the window where it is this file is. You have to open up the whole computer. Left upper corner desktop, or where you can see this screen of the videos of all the faculties.
Yeah, I'm able to see this screen. Okay.
That screen only you open up. Then you open up any folder or file. Then it will be useful.
So, are you seeing my screen?
Yes, I am seeing your screen, but click that video. Video we are not able to see.
So this is the video I have clicked.
Yes,
Yeah,
it
now
has
we
gone
can
down.
see.
It had gone down. It had gone down. Okay, fine.
Okay,
Now-
so
now
it
it's
is a
okay.
case where 28 years old male patient had left heel pain for more than 24 months and all conservative modalities failed. Patient is put in supine position with external rotation of foot. You need bright illumination and magnification. I use either a microscope or a loop. This is the position into which patient is positioned. And this is how I mark the incision for distal tarsal tunnel release plus a plantar fascia release. So the incision goes right up to the heel area. I release the superficial fascia of abductor hallucis muscle. So this is what I'm doing. I'm releasing the superficial fascia. Now I'm releasing the flexor retinaculum because I am doing a distal tarsal tunnel release together with this. So now abductors, deep fascia of the abductor hallucis is being released and abductor is being pulled upwards, and that's the deep fascia. You can see that is the release of deep fascia, and as you release the deep fascia, you see the nerve underneath it. Now I'm releasing the plantar fascia, partial medial plantar fasciectomy. Is just 4 mm by 4 mm of plantar fascia release. I don't touch the spur.
Just remove that notification of quick heal internal security. So that is obstructing little bit. Yeah, click that. Yeah, okay.
And then you check all your release with a Freer. Start from the top and come underneath the abductor hallucis muscle. Go right up to the plantar region. Give a two-layered closure, and this is followed by non-weight bearing for about 3 weeks.
There is a small request. I'm putting another request to you, sir. If you will share this video, we'll edit the final webinar video and put this video so that will be useful to the, if you allow to share.
Sure, I
Rajiv
will.
bhai.
I will.
Right. So I'm putting a different questions. So your flow may get disturbed, but people are interested to see things. So we may change, customize accordingly. Right, sir?
Yeah. Are you seeing my?
Yeah. We are seeing very well.
Yeah.
We are seeing.
Are
very
there
well,
any
sir.
questions for
The
plantar fascia?
questions are there. Dr. Mark has said he will do ultrasound guided steroid. Do you take the to the interventional radiologist, or you do yourself? Injection.
Yeah, I have the interventional radiologist to do it, but it
Okay.
would be good skill. I know that there are physicians that I work with who do their own with the ultrasound, but you need to be skilled at it, of course.
Is there any relation with the uric acid level? Because many times uric acid level is increased, and that relates to the plantar heel pain, or it's
Dr.
just a
Nikesh.
myth.
Dr. Nikesh, plantar
sir.
heel pain. Is there any relation with uric acid hyperuricemia?
Yeah, few cases may have uric acid hyperuricemia, but if it is proven, then only there is some role of uricosuric drugs. If the uric acid levels are normal, then there is no role of uricosuric drugs.
And again, similar question: chronic insufficient sleep and chronic dyspepsia are many times associated with the heel pain. What is the observation of the panelist?
Yeah, that is
If
part of the.
if you ask deep in the history, these are the two features many times seen. That is the observation of the one of the delegate.
Actually, that is part of the overall stress which the patient is going. So that may be the cause of the plantar heel pain, because those patients usually are hypertensive, diabetic with acid peptic disease, and physicians, they ask the patients to walk or to lose the weight. Usually they are obese also. Many times they have hypothyroid associated with it. So it's all associated conditions which forms the profile of the patients. So nothing correlating with the pathophysiology of the heel pain and the these diseases, but they are associated conditions which goes hand in hand with hypothyroid, with stress, with obesity.
Dr. Chua, do you find such cases in your country?
Not really. I think most likely, like Dr. Navin say, is a stress on the patient.
Yeah, absolutely. But that answer to the that local use of nitroglycerin patch, whether it is useful to increase the vascularity of the local area.
So local nitroglycerin patch, they work to increase vascularity more commonly at the posterior aspect of the heel. So I have been using, we don't have availability of the patch in India, but we have availability of nitroglycerin ointment or a cream. So I do use it for the cases who has got a posterior heel pain because of tendo-Achilles, insertional tendo-Achilles tendinopathy, which is going to be our next topic, which we are going to discuss. So next case.
Yes.
Question?
Now the
Yeah,
Dr. Sangin.
regarding
Okay, Still, okay, you answered. Then still 2 or 3 questions. So we have to complete that.
Because you want to add something?
Yeah, regarding nitroglycerin patch, one has to be very careful regarding the headache, and that may be disturbing. So always warn the patient about the pulsating headache.
Yes, that's very
They
common.
they might forget the plantar heel pain because of the severe headache.
Okay.
Okay.
Yeah.
Now the question is, any role of pregabalin, gabapentin?
Yes,
Yeah,
I mentioned.
only if it is a neuritic pain, then it has some role, but routinely it might not have any role.
So neuritic pain, when you confirm, then the pregabalin and gabapentin, they work wonder.
Dr. Sangin from the Bhuj has asked, any expert can take up a percutaneous release of the plantar fascia. I talked about the needling. Any percutaneous release of the tightness of the plantar fascia do you do before the open surgery?
So
No.
percutaneous release is fought with injury to the other important structures. So even literature has mentioned injuries to the nerves when you are doing endoscopic procedure. So percutaneous procedure in this area would be very, very much dicey, and you are always fought with the injuries to the important structures which are around. So I never thought of doing it percutaneously. I never know of somebody doing it percutaneously.
So now the people are increased up to 6189. So the questions are coming more and more, sir.
Okay.
How to differentiate between mechanical, inflammatory, and neurological cause of the heel pain? That is the basic question by Dr. Parth Gavatra. How will you differentiate these three? Because you talked about the mechanical pain, you talked about the neurological pain. How they will differentiate and treat that patient?
Yeah. So if you are talking about the neurological pain would be irrespective of the activity.
Okay.
That's a major important thing. Patient might have pain at rest, patient might have pain more at night also. Neurological pain could be radiating. Neurological pain would be showing shifting tenderness when you examine. And for a neurological pain, you would have tenderness at the soft spot. Neurological pain could be laterally located on the heel. So there are so many things which would be able to give you guidance with respect to different diagnosing the neurological pain. And you can elicit your tarsal tunnel stretch test and tinal sign for eliciting the neurological pain. Mechanical pain are the cases who have recent increase into the weight, recent increase into the weight bearing activity, or they have got either a pars planus or a pars cavus or some stoma or malunited fracture. And these people have pain at the toe of typical plantar fascia pain, and they have tenderness at the medial tubercle of the heel. So it is the location typical for the plantar fasciitis. And as Dr. Nikes mentioned, if you dorsiflex the great toe, it is going to stretch the plantar fascia, and you would be able to elicit the pain at the location of plantar fasciitis. So that is how you differentiate mechanical pain. Mechanical pain could be bilateral also if it is because of systemic problem. And the third you said is inflammatory. The inflammatory pain almost always is bilateral because it is originating from something wrong into the body. So normally it is bilateral. Inflammatory pain is also with the association of history of pain in other joints, pain in form of morning stiffness, and serological markers would be raised. You could also find certain cases with the gout, as Dr. Nikes mentioned. So these are the three different kind of pains which you could diagnose with the history, clinical examination, and serology.
Any role of NCV in neurological pain diagnosis?
Yeah, that's a fantastic question. So
this question is asked by Dr. Nitin Patil from the Maharashtra.
Yeah. So role
you
of
must give
NCV,
credit to him.
Yeah. And nerve conduction studies, if our neurophysician is really very much inclined and sincere in going through these nerves, because these nerves are very tiny, NCV eliciting would be very difficult. If they have real interest into doing EMG and if they can elicit the response of abductor hallucis and abductor digiti minimi, it could be of use. I do get NCV testing and EMG testing for the cases where I feel that the neuritic element is more than the other element. And for me to release tarsal tunnel as a complete tarsal tunnel plus a plantar fascia release procedure, I would have positive history, point number 1. Second, tarsal tunnel stretch test, point number 2. And third, NCV and EMG. If 2 out of these 3 are positive, then only I'll go in and do surgery. Otherwise, I'll treat this patient conservatively.
We are getting questions from the different states. Now, Dr. Taneja from the Punjab is asking whether in your initial practice you required the C-arm to get the injection steroid to exactly get the site, or you are doing directly. Do you advise to have a C-arm under C-arm?
Why initial practice? Yes, I used CM for pretty long time. Now I've got an ultrasonographer who is quite reliable for me. So I inject with the ultrasound. But yes, CM guidance, I would advise for everybody who is beginning to give injection, because you want to inject anterior to the calcaneus, you want to inject dorsal to the spur and fascia, you don't want to inject into the spur or underneath the spur.
Okay, and what will be the dose of Marcaine in posterior tibial block? It is the Dr. Dinesh Sharma from the Haryana.
Okay, so what I do is I take 2:1 sensorcaine, xylocaine and sensorcaine. So typically for a posterior tibial nerve block, I'll prepare a 15 to 20 ml of solution with xylocaine and sensorcaine plus a normal saline. So it's like 4 cc of xylocaine plus 2 cc of sensorcaine plus rest by distilled water.
Again, the question from the anonymous: how frequently you observe the stress fracture as the cause of the heel pain?
Yeah, can I ask Chua, who is quite well versed treating these sportsmen, at how often you have encountered stress fracture in your practice at Malaysia?
Not so common. Not so common. Yeah.
And Mark at Australia, a lot of cricketers, do they come to you with this stress fracture of calcaneus?
No, it's not a very common fracture. It is seen, but it doesn't usually come to me. It comes to the sports physician, who usually work it out. But the other group occasionally is elderly patient with osteopenia, and I've had patients, perhaps more of those with calcaneal stress fracture, maybe 80-year-old patient with osteopenia. That is a different case again.
Dr. Nikesh and Dr. Mahendra?
No, it's very rare to see a calcaneus stress fractures. But as Dr. Mark said, it's quite possible to have them in an elderly population who have osteopenia to start with. So I don't think it's a diagnosis that is more frequent.
Actually, the diagnosis of stress fracture is very evident from the history, from the examination. So normally, in a case of plantar fasciitis, there is not much confusion regarding the diagnosis of stress fracture in the plantar fasciitis.
Yeah, but how common it is in your practice?
Very rare, sir. Very rare.
Okay, Navin bhai.
Now the last question is to all the panelists. Somebody asked some personal question. How many of you have had a heel pain, plantar fasciitis in your life?
Yeah.
And what was your story?
Yeah, I had a plantar heel pain when I started with my yoga and exercises, and it just vanished over the span of 4 to 6 weeks. Dr. Chua?
Calf stretching.
Had you ever had a heel pain?
Yes. Treated with calf stretching.
Okay.
I had plantar fasciitis in 1998, and I was a triathlon competitor, and it took 2 years to go away, and I lost all my fitness, and I put on 6 kilograms.
Oh, that's a great experience. Mahendra,
So that was not
I
my
had-
fun.
fattiest out of all panelists.
Yes, so I'm feeling very pleasant that all of you are also having heel pain. I thought it was only because of my weight. So, yeah, I mean, weight gain, 1 kg of weight gain is 4 kg for the body. So you have to understand that even if you put on 2 or 3 kilos, heel pain and lower back pain are a very, very common symptom. I think I have also experienced it in my
So now
So
there is a
just
follow-up. Now there is
before
a
that, Navin bhai, before that, we have Dr. Nikesh Shah, who lost 32 kg weight. I want to listen from him whether he had plantar heel pain before he was, weighing like 32 kg more, which now he is not.
Yes, yes, I had plantar heel pain because of my attempts to reduce the weight by walking, running, cycling, exercising, jogging, everything, and it disappeared. You can say magically it disappeared with the weight loss. So definitely weight loss has its own advantages. I personally
now
felt
the now follow up logic question. Now follow up very logic question. If it has a relation with the weight, why many times it is unilateral and not bilateral? Weight is equal.
yeah, God is great. God has done you a favor
Good
that
question.
it has given only one heel pain. If it has given you bilateral, then you would be screwed.
But-
Thank God
right,
for that.
but
Okay. So I think now we need to move to, I mean, it's
yes,
like
yes.
6:30.
Any questions remaining, we'll ask later on. For the delegates, this is the announcement. So
Yeah.
because so many questions are pouring and pouring.
Okay.
Go ahead,
So,
sir. Go ahead, sir.
so we are going with the second office issue, which we quite commonly encounter in our practice. And this is a male 41 who came with the pain and swelling at back of the heel, and this is there from 5 months. So what all points, Dr. Nikesh, would you ask in a history of a patient who is coming with the posterior pain at heel?
Yeah, sure. The first is the duration of the pain, that and the progress of the pain over a period of time, how it has progressed, whether it has worsened, whether it has improved with some therapy. So history, then is there any history of swelling which is increased with the time or not? Also, I would ask regarding the history of pain after a brief period of rest, which is suggestive of tendinitis of the insertional Achilles. Also, I would like to take the history of their habits regarding the running, walking, or the hill climbing, which gives a fair clue regarding the etiology of the patient, and the type of the pain, whether it is diffuse or whether it is located at a specific point, and also if there is any history of popping or uh, some event which can suggest the rupture of the insertional Achilles tendinitis with the rupture. So basically, I would like to differentiate between the insertional and non-insertional issues, and whether it is associated with the rupture or not.
Mahendra, anything you want to add into this?
Uh, the two things that is, one is about the treatment modality, is one whether the patient has had any history of steroid injection in that area. That's number one. Second, whether patient is has taken any history of quinolones, and has taken any quinolone antibiotics, because that can make the tendon, the Achilles tendon, weak, and because it affects the collagen. Third, comorbidities like patient having diabetes, whether patient is a chronic smoker, because all these are going to affect my management plan. So I think history, these four things are also important in addition to what Nikesh has said.
Yeah, Dr. Chua, anything else into the history you want to add?
Yeah, I'd like to ask the occupational history, whether they are standing and what type of shoe they wear for the working. In the ladies in our country, in a bit more urban area, they like to wear high heel, which always got friction onto the posterior heel. That is make a bit of important factor to cause a pain.
So, Dr. Chua, what important clinical examination would you do for this case?
Yeah, same. Again, we do the gait analysis, ask the patient to walk, whether they have a pronation gait, and then look, feel, and move. Look at the alignment on the bone and on the heel, whether the heel can go into valgus or not, or go into varus. And of course, you can see there is maybe a swelling over the insertion of the Achilles tendon or over the non-insertion side. Then from there, we can differentiate whether there's a insertion or non-insertion. Yeah.
Okay.
And then, of course, the palpation is very important, because palpation is one of the very important part of orthopedic examination, whether they are at the insertion site, or whether they are non-insertion site, or where they are in front of the Achilles tendon. Then we can differentiate whether there's a patella, this tendon bursitis or not. Yeah.
So Mahendra, what are all insertional problems? If you could just narrate what all are the insertional and non-insertional posterior heel problem diagnosis, and how would you clinically by examination differentiate it?
I think in the non-insertional, the pain is more proximal. I mean, if you palpate the Achilles tendon from side to side pressure, that is usually a non-insertional type of tendinosis. In the insertional, the pain is located more distally at the calcaneus, and almost there is like a bump, like a bump on the back of the heel. And these patients are also, diabetes is one thing that you have to ask: history of diabetes, history of any chronic hypothyroidism, patients on certain medications. These are going to pinpoint towards more of an avascular problem towards the non-insertion, towards the insertional tendinitis.
Mahendra, then there are some bursae.
Yeah, there's a retrocalcaneal bursa.
Yeah.
There's a retrocalcaneal bursa which is between the skin and the tendon. That's more distal and more superficial. So that is another diagnosis that you have to.
And then Haglund's deformity, what is that, and how do you diagnose that?
So Haglund's lesion is basically a posterior superior prominence of the. So if you take an X-ray of the lateral heel, you will see the projection of the posterior superior part of the calcaneus. So this is what starts. There is a friction between the Achilles tendon and the Haglund's lesion. This is a primary problem that is has to be treated by excision of the Haglund's lesion.
Yeah.
The
Dr.
pain
Nikas,
is of the Achilles.
Dr. Nikas, anything else you want to add into clinical examination?
The tightness of the tendo Achilles, of course, that is to be seen, and the gastroc tightness, which is one of the cause of the insertional Achilles tendinitis. If there is any palpable tenderness which is shifting, which is suggestive of peritendinitis, wherein the tenderness shifts with the movement of the ankle, dorsiflexion and plantar flexion. But if it is a tendon issue, then it doesn't move along the movement of the ankle. So shifting tenderness is also one of the important feature which one should not miss.
Yeah.
Of course, the gap is always obvious to the palpation, but that is also to be looked for specifically.
So Mark, anything else is left out into the clinical examination of posterior heel pain cases?
Well, I will say that the posterior heel rarely, but more so than one would like, is a site of a lesion, such as a tumor, like a fibroma, a ganglion, a calcific tendinitis, and occasionally accessory musculature, such as accessory soleus. So that's something that you would need to just keep in mind. And I think we've mentioned already the possibility of Achilles rupture, and also if there is some inflammatory disease. And I think rarely sometimes an infectious disease such as TB can cause Achilles problems, I think. So, but if we're looking at a standard Haglund's type syndrome, I think we've covered everything that I would be interested in.
So I'll run through some few quick slides that it is all about index finger of patient or examiner, where you want to really examine. And you should be differentiating the pain. If it is at insertion, it is insertion. If it is above, it's non-insertion. And then in tenderness, if it is anterior to the tendon and above the bone, and if it's a soft tissue swelling, it is a retrocalcaneal bursitis. If you have a bony tenderness which is anterior to the tendon and at the insertion, it is Haglund's deformity. This is how it looks like. And if you have a tenderness and bowy swelling which is posterior to the tendon, inferior to the insertion, that is Achilles bursitis. And if you have bony tenderness at the insertion, soft tissue tenderness at the insertion, it is the insertional spur plus insertional tendinitis, like you are seeing in this X-ray picture. And sometimes there could be a pop or history of local steroid and injection, and then it ruptures. So this is how there could be rupture. But the most important thing is that in a clinical setup, you could have every possible combination existing partially or fully. Before going to management, Dr. Chua, what all investigations you would do for these patients?
I'll do a standing weight-bearing X-ray on the ankle, AP and lateral. Yeah.
So why would you do standing X-ray? Why not non-standing X-ray?
I just want to see the whether on the weight bearing whether the calcaneum pitch angle whether they are okay or not, or whether they are reduced, and this will help us to rule out some other thing else. Yeah.
Mahendra, what else would you do in the investigations?
In the other investigations, if you want to see more of the condition of the tendon, whether you're suspecting an MRI is a very good modality to look at, because that will not only give you a clear-cut idea about the extent of the disease, but also associated problems that could be arise. All the bursa inflammation, the inflammation of the tendon, or a partial tear can be picked up. Ultrasound also is a very good modality to look at all these issues.
Dr. Nikesh, you go for some serological investigation for these cases?
Yes, to rule out the other causes like inflammatory arthritis or some uric acid issue, rheumatoid arthritis. For that, we can go for a serological test. Also, in the MRI, I would like to look at the thickness of the tendoachilles. If it should be less than 6 millimeter at the insertion of at the distal part of the tendon, and it can be classified according to the thickness, type 1, 2, and 3, according to the thickness. If it is more than 8 millimeter, it is type 2, and if it is more than uniform degeneration, then it is type 3. So that's how you can classify also according to the MRI picture. If the degeneration is less than 50%, then it is type 2. But if thickness is more than 8 millimeter and degeneration is more than 50%, then it is classified as type 3. So MRI is also very important to manage these patients and plan our treatment before any surgical procedure or the conservative treatment. And also it is important to explain the patient regarding the prognosis and the recovery period and the expectation of the recovery. And also it guides regarding the chances of rupture during the conservative treatment if there is no rupture. So if there is a significant degeneration and patient can go for rupture at any time during the treatment. So that is also one of the important point one has to remember. During the treatment, if patient gets rupture, so that can be diagnosed before and with the MRI, the possibility.
Mark, in Australia, you get MRI for all these cases? And how
I think if they are not responding to simple treatments, such as rest or a moon boot or physiotherapy, and they are and they're symptomatic after 6 months, then and we're considering whether or not surgery is going to be an option, then an MRI scan is a very good test, and because it will demonstrate bone, tendon, bursa, and exclude other diagnoses as well. So I think it's a very good test.
So what
at
are
this
your
point.
all are your conservative modalities? You said physio.
For me,
Hmm?
so the simple, if you feel, if I feel this is one condition where a period of time in a moon boot is very beneficial. So if I really wanted to settle a patient down, I would put them into a moon boot weight bearing for 6 weeks. They may or may not sleep in the moon boot, but usually when they're walking around, they can have some stretching exercises with physiotherapy, and then analgesic, usually short-term anti-inflammatory or paracetamol. And then I would hold off on cortisone anywhere near the Achilles tendon. Only if I thought they had severe retrocalcony or bursitis would I give them a cortisone injection. But that's the mainstay of the conservative treatment for us.
So Mark, you made a fantastic point that no cortisone injection at the insertion of Achilles, otherwise it would rupture the tendon. If at all
Very
you want
much.
to inject, you can inject anterior to the tendon into a retrocalcaneal bursa. Dr. Chua, what all additional conservative modalities you use
Yes.
in your practice at Malaysia?
May I show my slide?
Yeah, please.
How to show my slide?
Navin bhai. He
Sorry. Just share
wants
the
to share
screen.
his,
Yeah, just share the screen. His will remain
Yeah.
like that in the background. Yours will come in the forefront. And
Yeah,
when
yeah.
you will stop sharing, immediately his will come.
Yeah. So
Yeah.
this, can you see the slide?
Can you make it full? Can you make it power so?
slide
Oh,
show.
yeah,
Slide
sure.
show.
Yeah. Slide show.
Yeah.
Yeah.
So this stretching board is very, very helpful because when you ask patient to use a towel to pull on the foot, how strong they are going to pull, nobody know. And how much force they're going to pull, nobody know. You can ask them to stand on a staircase, but there are high chance of may fall down or anything. But this is a special board of about 25 degree. Second level is about 35 degree. And when you ask patient to stand on this, even they have a plantar fasciitis or posterior heel pain or the tight Achilles tendon, this stretching board will be very, very helpful. If they do this sincerely for 5 to 10 minutes, 2 times a day, and most of the pain should be subside. And then come to the X-ray that I mentioned. These are the few X-ray that you may able to see. When the patient have the Achilles tendon pain, when you do X-ray, they may not have a lot of spur here. And on the B, they have a big heart lung deformity over here. And then over the C, and then they have this big spur here. So from these 3 X-ray, I would say that for the patient A, if they have pain and feel non-operative management like calf stretching and short term of NSAID, then I may give them a little bit of PRP over the Achilles tendon site. And then for the B, the PRP may not be successful. And then for the C also, the PRP may be just successful about 50% because the main problem is a big spur here. Then come to this, there is a calcification over the tendon. And this case, if you inject PRP, it may not helpful also. And then with this, the X-ray E, there's a worse because there is a big spur here, and then there's a calcification there in the Achilles tendon. And for this is even the bigger spur here. But don't treat patient by X-ray. How big is a spur, but they may not have pain. If they have pain with this big spur, then only if the non-operative fail, and then we offer some surgical intervention. If they even, because some patients even they have a small spur like this, but their pain is excruciating after the non-operative treatment, then we may do the operation. But some of these patients, even with this big spur, they are asymptomatic after the non-operative management, then we will leave the big spur alone. Yeah.
Okay. Fantastic, Dr. Chua.
Yeah.
So
How to
you don't
understand?
use shockwave?
No, I don't use shockwave in my practice.
Mark, do you use shockwave for these cases?
You share it. Raju bhai, you share it.
Uh,
Just share it. It will be automatically from that slide only. Just share the screen. That's all.
okay. So Mark, do you use shockwave for your cases?
I think Mark is not there on this table. He must have just left for some.
Okay. So any other treatment Mahendra or Nikesh would do conservative
Just leave them.
modality?
Eccentric stretching exercises. If there is an insertional tendinitis and there is no rupture, then I will go for eccentric stretching exercises, so which will be the main form of the treatment. And we need to explain to the patient how it is to be done properly. And also we have to warn the patient that for initial few days the pain will increase because of the increased vascularity, but ultimately that will always regenerate the collagen fibers, and there will be permanent relief of pain with eccentric stretching exercises.
Any of the faculty uses nitroglycerin patch or the ointment or the gel for posterior heel pain?
As Nikesh Bhai said, I used it a couple of times, but the headache is something that really gives a headache. So I think it's something that you have to use with caution.
Okay. Nikesh, have you used that?
No, sir. I have used in one or two patients only, but because of the headache, I discontinued, and now I'm not using it for any patient.
So, Mark, how long do you try conservative modality before going for surgical intervention?
I think Mark is not there on his chair.
Okay. Okay. So, Dr. Chua, how long do you try your conservative modalities before contemplating surgery?
Yeah, at least 6 months.
6 months.
6
Mahendra?
months, yeah.
6 months at least.
Nikesh?
Yeah, 6 months.
6 months. So 6 months of conservative therapy, when fails, then you go in for the surgery. So Dr. Chua, if the patient has got retrocalcaneal bursitis plus Hegland's deformity, how would you treat that patient surgically?
Surgically for the heart lung, I would just use endoscopic to debride the heart lung. But if there's a big spur, like the X-ray that I show, then I will do a calcaneoplasty where I to detach the, I use a posterior approach, and then to detach the Achilles tendon, to take out the spur and the insertion of the Achilles tendon by ankle suture onto the calcaneum.
So he made a fantastic point that only and only minimally invasive procedure would work provided the disease is not into the tendon or there is no insertional spur. If it is a pure case of Hegland's deformity, you can go with a medial or lateral paratendon approach and excise Hegland, but make sure that disease is not into the tendon or there is no insertional spur. Mahendra, had you had any case where you operated retrocalcaneal bursitis?
It's actually usually part of the whole problem. You don't specifically go. If you have a specific retrocalcaneal bursitis, then you could go posteromedial approach and get the bursa out. And in this case, actually, an endoscopic debridement would work much better instead of doing a big incision.
Yeah. So, Dr. Nikesh, for an insertional Achilles spur and tendinosis, how would you surgically approach it and how would you do the surgery? Like that you are described or you want to describe it?
Yeah, first I would like to assess with the MRI what is the type of the extent of degeneration and whether there is any rupture or not. So if the degeneration is less than 50%, then I would like to conserve the Achilles, and so I will go from the lateral aspect and remove the spur from the lateral aspect. I may not touch the tendon if it is less than 50% degenerated, but if it is more, then I would like to go from the midline, split open the tendo Achilles, remove the spur, and at that time physically I will examine the degeneration, and whatever degenerated part I will remove. And if more than 50% of the tendon is removed, then I am obliged to do FHL transfer in the same sitting.
Dr. Mahendra?
Yeah, almost exactly the same thing. Because if you have removed more than 50% of the tendon tissue, and here there is a point that I would like to make, is that we must be extremely aggressive in doing a tendon debridement till we reach a tendon which is healthy. Any yellowish tissue which doesn't look like a normal tendon, any tissue that feels gritty, has to be excised. So do not fear. You have to be extremely aggressive in doing a debridement, and you have always sure that if you have removed almost more than 50% of the tendon, you always have the FHL to protect your repair. I think this is the key message that has to go.
So do you see the image when you operate these cases to make sure that you have removed the adequate bone?
Yes, yes, absolutely, absolutely, absolutely.
So any tips on to removal of bones?
So you have to basically draw a line extending up to the posterior facet, and anything above that line, the bony lesion has to get off. You have to have a flat surface and be extremely aggressive. I mean, whatever is there has to come out. Do not leave any tissue there.
Dr. Chua, how do you intraoperatively decide that this is the bad tendon and this is the amount of bone you are supposed to remove? So two questions. How do you decide the amount of bone to be removed, or what is your endpoint of removal of bone? And how do you decide that this is a bad tendon?
Yeah, clinically, you can actually feel the prominent bone, especially at the posterior side. But when you are start doing this, then the X-ray will be helpful, intraoperative X-ray, to make sure the posterior spur will be removed. Because sometimes we thought we are removed, but after the operation, you do an X-ray, actually it's still not removed yet. But sometimes when there's a lesion calcification inside the tendon, then clinically you can see that. But when you remove the posterior prominent bone, don't forget to remove the lateral and the medial wall, the sharp edge over there, to make sure that they are smooth. Otherwise, when you remove one prominent, you will leave with another two prominent at the medial and lateral heel. Then from there, you will make sure that the adequate bone is removed. And then for the tendon, yes, clinically you can see the healthy tendon, or some tendon look like fibrous tissue, scar tissue, not really vascular. Then you may need to remove. Especially you can see the inflammation, in front of the tendon. There's a lot of inflammation, and the retrocalcaneum flat pad, there's a lot of inflammation there, and a scar tissue, you may need to remove that also.
So you made a fantastic point that not only the bone from posterior aspect, bone from the medial and lateral aspect also requires to be removed, because many times that is more prominent than the posterior prominence. And you also said about the quality of the tendon. Now, Dr. Nikes, when you do this surgery, you are left out with the defect. There is a defect between the end of the tendon and the bone. So how do you bridge this defect? Do you have some algorithm in your mind which you use?
Yes, that depends on the length of the defect. If the defect is less than 2 centimeters, then usually that length is achieved by constant pulling the tendon ends with the holding with the either strong suture or the Alice forceps, and a constant 2 to 5 minutes of the stretching will allow us to have around 2 centimeter of length. So, and if the tendon repair is not under tension, then that is acceptable. But if the gap is more, or if the tendon is under tension, like 2 to 5 centimeter gap is there, then one can go for either one can extend the incision proximally, and one can go for VY-plasty to have the tendon length and the tendon ends to be opposed, or one can go for central turn down procedure to cover the gap. If all these things are done, then one has to be very careful that the strength of the tendon is decreased with all these procedures. if the gap is more than 5 to 7 centimeter, and of course it is not possible to oppose the gap, then FHL transfer is the only answer one has to rely on. And the distal end of the stump is sutured with the FHL belly so that it has some vascular supply. So it depends on the gap. In summary, like if it is less than 2 centimeters stretching, if 2 to 5 centimeter, then local proximal procedures like VY-plasty or turn down. And if it is more than 5 centimeter, then you can go for FHL transfer only.
Dr. Chua, your algorithm of defect management?
I think for the insertional Achilles tendinitis, surgically they seldom have the defect. But if you are doing with the non-insertional Achilles tendinitis, then sometimes you may get a defect. And then the defect will be sometimes more than the whatever primary repair that you can take. And then I will use a FHL repair or the VY-plasty.
Now, Mahendra, why do you use flexor hallucis longus or you use peroneal also? And why not?
So the FHL is one of the tendons which is more in the directional forces in the direction of the Achilles tendon. Secondly, the belly of the FHL is very vascular, and that also will add to the bringing the vascularity towards the. So I usually go for an FHL transfer, but peroneus longus are also used in literature, showing good results. But I haven't done one. But FHL transfer for me is the workhorse for this condition.
Dr. Navin bhai, it's now 7 o'clock. So should we be taking questions?
Yeah, we can take small 2 or 3 questions. The one question is in Haglund, debridement done through a vertical incision or a transverse incision?
Okay, Navin bhai, for that, let me run through.
Is there any video? Is there any video?
I'll just run through this slide,
Okay.
and in the slides only, I'll be able to show. If
there
it
is
is
a video,
Haglund,
it is okay. Okay.
Yeah, if it is Haglund plus retrocalcaneal bursitis, you could take paratendon lateral or medial approach, plantar the ankle and remove the Haglund and remove the bursa. You could take lateral, medial or posterior approach for this. And this is the typical presentation of our cases. Incisional spur, tendinosis, Haglund plus retrocalcaneal bursitis. And then, as Dr. Chua and Mahendra and Nikesh described, a posterior heel splitting incision, and then removal of the offending bone, bad tendon, and use of suture anchor or a bone suture to suture back the Achilles. And then the rupture, again, you have that defect management algorithm, very nicely described by Dr. Nikesh. That is the VY-plasty. And then this is the central turn down, where you the part of the tendon, turn it down, and this is the FHL transfer. It is a single incision transfer. You use a bit pin and interference or a biotenodesis screw and fix up the tendon. And you could also do double incision transfer for a longer gap. You can take it from the plantar aspect with a minimally invasive approach. Pull that tendon out. This is the FHL, and then this is the length you get, and you can route it through a tunnel into calcaneus and tie it over itself. This is how it looks. So that's all. We take questions.
Yeah, the previous talk, some people have started late little bit, but there is a question. It was pending from Tanna sir. It has come on the WhatsApp. Tanna sir's observation is when the pain is severe on walking all the time, hitching, I think there is nothing sort of depot injection will help when the pain is continuous, not on initial steps and then goes away. What is the observation, sir?
Yeah, so all the panelists, they said that they do use steroid injection, and Dr. Mark was saying that there are 2 types of patients he differentiates. Chronic resolving plantar fasciitis, where this would not be required. But those cases which are of chronic recalcitrant plantar fasciitis, they do respond to injections and they are being used. Okay, next question.
Okay.
Any question
Then the
about
Dr.
insertional
Rajiv Rai
tendonitis
Chaudhary, first let us finish this previous one. Dr. Rajiv Rai Chaudhary from Surat. If a tight tendo Achilles is a probable cause of plantar fasciitis, then would a tendo Achilles surgical release help in recalcitrant cases?
So sir has joined late. There are a group of surgeons who only do for any heel pain, they only do gastrocnemius release. And
Okay.
there are a group of surgeons who do gastrocnemius release when they find it to be tight, and it does help in problems of insertional Achilles tendon.
And
I
what is
find
the-
that a very good operation in patients where I'm worried about the wound. If diabetic or smoker, I would do a endoscopic gastric release and then wait to see if the pain had resolved. And that's a very good option in patients where the operation on the heel or Achilles is high risk.
Thank you, Mark, for being
Okay.
back with us. Okay, next
Yes.
question.
Any role of pre-op CT cut along with MRI? Which area of calcaneum impinges the tendon in the Haglund? Does it help? CT with MRI.
Yeah. So I was with Professor Van Dyck, and he almost always gets CT scan, then MRI for insertional problems. His logic is that the MRI gives you magnified picture of the damage of the tendon. That's one thing. Second thing, he says that CT scan is going to tell him that what is the extent of a prominence of the bone impinging over the tendon, and according to CT scan, he plans the treatment as well as he counsels his patient that in this case I'll be able to get out with just suture anchor, one suture anchor, two suture anchor, or in this case I might require reattachment of the whole tendon. So there are doctors who do use CT scan a lot in such cases.
Okay. How much the incidence of tendon rupture after the injection in the retrocalcitrant bursitis? Steroid injection, TA rupture incidence.
Okay. So if I am to answer this question, I inject into retrocalcaneal bursitis cases, which are cases associated with seronegative arthropathy. And they are the cases who do not respond to your conservative management. I inject them after failure of 6 weeks of conservative modalities. If they fail, then I inject them. And these are the cases which are pure retrocalcaneal bursitis. There is no problem whatsoever in tendon, or there is no offending bone. If you find that, that is the case where you inject, otherwise you don't inject.
Okay.
I
The doctor.
I will prefer a PRP injection in case of Achilles tendon as compared to steroid. I never put steroid there. But if you need an injection, sometimes PRP will be helpful.
That's a great picture somebody has sent.
Yes, Dr. Karkhanis has sent the picture to share with us stretching exercise which he follows in his clinic.
I follow Dr. Karkhanis for all basics in orthopedics, which he has a fantastic way to teach. Thank you,
Yeah.
Dr. Karkhanis.
Yes, he has sent. That's why I have shared it with you. Now there are only few questions are remaining. Incidence of wound healing issue in this area with the after Haglund treatment.
Excellent question. Mark, would you like to answer this?
Well, the main thing to consider is your incision, and the longitudinal incision is appropriate. The other thing to consider is the comorbidity of the patient, because that is the number one cause for wound problems. So diabetes, smoking are the two conditions which will almost certainly give you wound problems. So you would have to be very, very clear with the patient that if you do surgery for Achilles and they have either of those two conditions, that there is almost certainly going to be severe wound problems. So you have to choose not to do surgery or to do something else, and that is the safest way in those situations. But you do get small areas of wound delay in Achilles surgery, particularly in the insertional, but they're never full thickness really. And if you take care and keep the wound dry and clean for 2, sometimes even 3 weeks, it usually heals quite well. But each case and region is different. You know, if you're in a very humid, hot area, is different to a cold area. So that, I think that patient selection is the most important.
And
Dr.
how
Chua.
to prevent the neurological problem in Haglund surgery? Neurological
Chua.
problem.
Dr. Chua, had you had any neurological problem in Haglund surgery?
It's not something that neurological problems are not something that I have confronted, but you have to protect the tibial nerve, of course.
Okay.
Dr. Chua?
Yeah, if you do it carefully, you shouldn't have injured any nerve over there.
I had a case where I did iatrogenic injury to the sural nerve because there was a big Haglund, big posterior and medial and lateral calcaneus projection. So while you go dissecting subcutaneously on the lateral side, sural nerve is at risk, which you should be taking care of, which I did injure in one case.
What is the cutoff time when you do a FHL substitution? What is the gap? What is the minimum gap or maximum gap is required to include the FHL substitution?
So, as Dr. Nikesh said, 5 centimeter, but for me, any gap which is 4 centimeter or beyond, I go in for FHL transfer. I am more and more towards FHL transfer as I am seeing my own cases and as I'm interacting with the foreign faculties. Because the central turn down and VY plasty, they all have their own problems. And that's why I've switched more onto transfer of flexor ollicis longus. I have less this thing for doing a FHL transfer. Dr. Chua, what is your opinion?
Yeah, I think I agree with you. I prefer the FHL transfer than the VY-plasty in case of big gap. For about 1 or 2 centimeter, then VY-plasty may work. But if more than that, then maybe FHL will give a better function.
Mark, what you do in Australia? What is your protocol? When do you do transfer?
We mainly would do FHL transfer. We don't really do turn down or VY plasty very much. Do you add Achilles lengthening or a gastrocnemius recession with your insertional repair? Because I routinely would do a gastroc recession when I do an Achilles insertional repair, and that gives you a bit more length, so you don't need to do it as much, do that FHL transfer very much.
So to answer this question, I have started doing gastrocnemius recession and trying to pull the tendon back, then doing this VY or central turn down. And I almost switched on to FHL transfer, then doing VY or central turn
Rajiv, can I make a point here?
Please.
Yes, sir.
Yeah. So the FHL transfer not only protects the repair, it brings in more blood supply towards the diseased tissue.
Absolutely.
Yeah.
So the FHL belly is so vascular, so it not only takes care of a mechanical problem, but also a healing issue. So
biological issues also taken care of.
It's a biological transfer. So in addition to a mechanical strength, FHL brings in blood supply to the diseased tissue. That is why we should do it.
I think it's a very good option.
Yeah, Rajiv bhai, Dr. Parth Gawatre is sharing with you. Dr. Rajiv did 3 long FHL transfer for my patient after discussion with you. All are doing excellent. I did VY plasty with FHL augmentation in one case. Your opinion, is it right or wrong?
So you sometimes in our cases which come late to us with a neglected rupture, or the cases which come with the infection, you sometimes do two-stage procedure, and there you need a long length of flexor hallucis longus. So you could take double incision flexor hallucis longus, or you could even harvest FHL with triple incision, taking an incision at the level of interphalangeal joint of the great toe. And you can route this flexor hallucis longus through a tunnel into the calcaneus. With respect to attaching tendo Achilles with the FHL, yes, you may pull tendo Achilles with VY-plasty, but when you're using FHL transfer, you just need to pull tendo Achilles and make sure that you attach that portion of the tendo Achilles with the FHL and give some additional strength to your FHL transfer. You may or may not do VY-plasty together with that.
Now the very finer aspect is asked by again Dr. Parth Gawatre. If a stump of Achilles tendon is left after the scar tissue excision in chronic tears, do you use that small stump for FHL augmentation, or leave it and just do a calcaneal tunnel and use that FHL tendon only? You are not using that
Yeah, as I said,
stump.
the stump of tendo Achilles is sutured with FHL. As in as much as you can pull it down, you just pull it down and suture it with the FHL. As Dr. Mahendra mentioned, FHL augments the blood supply of the tendo Achilles, and you're also getting the strength of tendo Achilles augmenting the strength of FHL. So that's what I do.
Dr. Vasu from the Vijayawada is asking, do you immobilize with POP after surgery to avoid the problem of wound healing, and how long?
Fantastic question. So these patients are immobilized into gravity assisted plantar flexion or dorsiflexion. So these patients we operate in a prone position. When we operate this patient, we paint and trap both the lower limbs because we want to match the tension of your transfer with the tension on the opposite side. You don't want to over or under tension. And then you flex the knee after your surgery is done, after your repair, after suturing is done, you flex the knee to 90 degrees. And whatever position ankle remains, I put in an anterior slab to immobilize ankle for 3 to 4 weeks. Dr. Chua, do you do something different for these cases?
No, I use anterior slab for 2 weeks. And for all my foot and ankle cases, I put them on back slab, either the anterior or the posterior back slab for 2 weeks until the wound heal. This will be very, very much helpful to minimize any wound gapping or infection of the wound for the foot and ankle surgery case. And then for Achilles tendon, after 2 weeks, I will change them to a pneumatic walker with the wedges. We start with 3 wedges, and then every week we remove one of the wedges on the top. So by 4 to 5 weeks, they will walk with the puntigrade ankle with the walker still. So after 2 weeks, we start them on weight bearing with walker with 3 wedges.
Dr. Mark, anything different?
What I would say with the rehabilitation, I do the same as Chua, but there is a significant stage that they need to pass before they come out of the boot, is that they need to have their pain that they experience first thing in the morning to have disappeared. So usually around 6 weeks, the startup pain will go. And once that pain goes, I know I can move them to the next stage of the rehabilitation. So I keep them in the boot until that pain will go, which sometimes it's early as 4 weeks or maybe as late as 8 weeks, but that will signify that the repair is stable and that they will be able to withstand the next phase of rehabilitation.
So Dr. Nikis, when do you start weight bearing with these cases?
If FHL is done, then I will wait for at least 8 weeks. And after 8 weeks also, I give them that
Walking cast.
walking cast or the hair cast splint and then allow them to walk with that splint. I
Mahendra?
protect them for at least 3 months.
I would first protect the incision at least for 3 weeks, irrespective of what the got, because I don't want my skin to break down. So protecting the incision for 3 weeks is my priority. At the end of that, I would put the patient on a cam boot like Dr. Chow, to put a graded heel raise and then gradually reduce it. And by maybe 2.5 to 3 months, I can start with full weight bearing.
Dr. Navin bhai, I think
Now the question is from Dr. Aradhana Rathod. The follow-up question of FHL transfer. Has anybody has experience of FHL transfer has failed, and what shall be the treatment then?
yeah. So if FHL
I have not
transfer,
had that experience.
yeah, if FHL transfer fails, then you can use either FDL or tibialis posterior or peroneal. But I don't know experience of failure of FHL transfer. Anybody in the panel had experience of failure of FHL transfer? Jua?
Refer to your enemy.
Refer to an enemy, right?
I think the
Refer
end
to India.
stage, if you can't get the Achilles to work, is ankle arthrodesis.
And Navin bhai,
But
Okay, the
there's probably
last
other
question.
things to
Last,
try.
yeah, because it's like 12:30, I guess, in
Australia. I know the last
Yeah, it's a
question.
bit late.
Sorry, Dr. Mark. Last question from again a foot surgeon, Dr. Girish Motwani from the Nagpur. Role of isolated plantaris release, ultrasound guided or percutaneous or open in non-insertional Achilles tendinosis.
Mark, would you like to answer this question?
There is a small role for this in occasional athletes, but is not something that I have done or that I would do. But there is some cases where this has been used.
Okay. So Navin bhai, I need
Yes,
to thank,
we are stopping here. Do you want to go ahead? No,
yeah,
I think no.
I just want to thank Mark,
Yeah.
Tua, Dr. Nikesh and Dr. Mahendra and obviously you for this. And maybe Mark would want to say one or two lines for Asia Pacific Foot and Ankle Council, of which we all are the members.
Oh, thank you, Dr. Rajiv. And I'd like to formally thank Dr. Navin and Kesh and Mahindra and Chua for their involvement and organization. It's been a wonderful privilege and I'm glad to be involved. And on behalf of the APOA, I'd like to welcome any surgeons or doctors to involve themselves in the APOA business, as we're a great organization and always welcoming for involvement and new members. And we hope to see you again either at a Zoom conference or a real conference one day. So thank you very much.
Right. So on behalf of the Gujarat Orthopedic Association, I thank all the faculties, particularly Dr. Mark, Dr. Chua, and Dr. Mahendra and Nikish bhai, and our own Rajiv bhai for organizing such a wonderful webinars. I think he's having one more in the pipeline, because every time certain subjects which he has marked remains unattended. Is it there? Is it there in your sleeves?
Yeah. we can take more. Yeah,
Okay.
because
Okay.
we missed on to metatarsalgia, we missed on to anterolateral ankle pain, which if in demand we can take later.
Okay.
We can do another one
We'll
next time.
get the feedback and they will come to. Just now I'm stopping the live.